Well, I'd like to welcome everybody. It is such an honor to be up here and to be a part of MetaECHO and to celebrate 20 years. I am just so thankful that you could all be present today. Well, we're excited to share a little bit about palliative care across the globe. I am so thankful to have my dear friends and esteemed colleagues up here with us today. One of the things that I'll share is, introductions. We've placed our names up above so that we could just dive in and really start to explore what does palliative care look like across the world? And most importantly, how has ECHO been leveraged to really transform communities? And one thing I'll share is make sure that you write down questions or comments, because we're going to try to leave a little bit of time at the end to be able to do that. One thing I'll share a little bit about myself. So I'm a palliative medicine physician here at the University of New Mexico in the Division of Palliative Medicine. And I've been so fortunate to have the opportunity to work with indigenous people. And I want to recognize that we happen to be on indigenous lands. And I'm so grateful and humbled by the opportunities to work in the Alaska Tribal Health System, Indian Health System, and with Pueblo tribes across New Mexico and Arizona. One thing that I've learned that has really impacted me, especially in the work of palliative medicine, is how important story is. The story of our patients and our families are the foundations of palliative care and really help to shape what we do. And these stories are so integral, especially amongst all of you with your echoes. And so I hope today, as we share our stories, that you can glean how some of the innovations of how ECHO has been used and leveraged across the world, these innovations can be applied to each of your echoes. And that's what's so great about MetaECHOs. We come together to learn from one another. And so we have Dr. Raj Gopal with Pallium India, and so thankful for him to be here. We have Dr. Megan Doherty, who is with the Two Worlds Cancer Collaborative, who, what's amazing, has spread echoes throughout the world in a number of different countries, especially Southeast Asia and parts of East Africa. And then Max Watson, Dr. Max Watson, and Professor Max Watson has been an inspiration to many of us with not only palliative care echoes, but echoes across many specialties, and especially being at the UK Hospice. And so we're so thankful that you could all be here. I'm gonna open up with our first question. And the thing I wanted to ask all of you, and we'll start with you, Raj, is just thinking about palliative care. Palliative care has so many dimensions to it, but it also looks so different in different communities across the world. So I just wonder if you can give us a little bit of a snapshot. What does palliative care look like, and how has Pallium India just been able to reach out in your communities? So I'll start with you.
Thank you. The differences that we come across when I have seen not exactly Max's program, but the palliative care programs in that country and here. The difference is, one, the magnitude, the enormity of the problem. In my country alone, we have 7 to 10 million people in serious health-related suffering. We are possibly reaching around 4% of them. But we are greedy. By 2030, we want to get there. And for that, ECHO very clearly is the route. We couldn't possibly train healthcare providers in person for all these, to cater to these needs. But then, one peculiarity which I expect I must be sharing with 84% of the rest of the world, apart from high-income countries, the low and middle-income countries, is when we come across patients, their suffering is also because of poor fundamental health care. When our team goes out on home visits, they cannot just treat pain and symptoms and address emotional issues and walk away, because the diabetes is uncontrolled, the hypertension is uncontrolled. The team also has to care for primary health issues. We can't just say that's not our job. If I met a man in the monsoons who was holding up an umbrella in his home, advanced cancer, he couldn't lie down because the roof was leaking. They no longer had the money to repair the roof. And how do you tackle that? And that was my final point. Without involving the community, it cannot be done. Yesterday, from the floor, from the one speaker, we heard it is a myth that we cannot get the community to help unless you pay money. They proved it. We prove it. The poorest, the poor, people come and help to pull a tarpaulin over the roof. We have to provide food kits for those who are starving. They wouldn't ordinarily be starving in my state of Kerala, but when disease strikes, they starve. So we have to, the magnitude is enormous, and the dimensions of the suffering is not just a disease. It's much more than that. And when we put the social determinants in a box and keep it there, as if it is somebody else's problem, it makes our work meaningless. Thank you.
Thank you, Raj. And Megan, I know you've worked in numerous countries, and so I was just, how does the tenets of palliative care look across the places that you've worked and used and applied to ECHO?
Thanks, Chris. So I have been working and working with teams and leading and developing pediatric and adult palliative care ECHOs in India, Nepal, Bangladesh, Sri Lanka, Bhutan, Philippines, and from that we have seeded many other ECHO programs as well across Africa, East Africa, French Africa. So there's a lot we can see that is common. You know, I think one thing we really emphasize in all of our programs is this compassion, and how do we awaken and give a voice and a place for the compassion to come out, because many of the people who join our ECHOs, they just don't know how to help that child that they're seeing. You know, they may see a child, for example, last week we started an ECHO in Sri Lanka for pediatricians. And as soon as we started talking about, like, what children do you see who might need palliative care, they start listing off children with all these chronic conditions, and they just say, they come to my hospital and I don't know how to help them. I don't know what to do for a child with cerebral palsy. Like, my hospital isn't equipped for this. And so a lot of what we're doing is giving tools and ideas and a way of looking after children. And it's not just about the medicines. You know, a child with cerebral palsy, it's not really very much about the medicines. It's about everything else. Exactly what Dr. Raj said. We give food packets, you know, because when we were doing palliative care programs for children who live in urban slums, you know, the family's like, well, it's very nice you're seeing my child, but, like, really, all my other children are very hungry. So, like, you're kind of wasting your time if you just come and visit this child with cerebral palsy and do stretching and give them their medicines. What we need is a roof over our head. What we need is food. And so you have to listen. I think the lesson is to listen to the community, partner and join with them and say, you know, this is our philosophy in palliative care. You know, we want to address suffering, improve quality of life. What does that look like in your community? And you're the experts in your own community. And, you know, we bring in community health workers who are members of the slum community to say, what does it look like? What do you see as the needs of your own people? And they drive the project forward for us.
Thank you, Megan. And I hear social determinants of health, and I know all of us and all of our ECHOs, those are interwoven, important issues that impact all the work that we're doing. So it's just so helpful to hear just how important that is. Max, I wonder, with the many ECHOs that you're a part of in the UK, just can you share a little bit with us some of your perspectives about tenets of palliative care and how it does weave through many of the echoes that you're a part of.
Thanks, Chris. I'm just going to first say I had the privilege of walking beside Megan at the Indian Association of Palliative Care Congress back in February, and people coming up to her from all over the place saying, "Oh, you're Megan. You're so small. I thought in Zoom you'd be much bigger." She had a human connection through Zoom with people from right across South Asia. That human connection is part and parcel of the energy of ECHO to really change and support people. In terms of palliative care, I think palliative care is the sort of care that you would want, that I would want, if we were approaching the end of life. And it's about mitigating suffering. And suffering's a slippery beast. It needs a head, heart, and hands approach. It's your umbrella and fixing the roof and fixing food, as well as opioid receptors and all of that stuff. Last week, Joan came to see me in my hospice. She hadn't wanted to come anywhere near a hospice because she's 37 years old, she's got 5 kids, and she's got metastatic bowel cancer, which was diagnosed at her last pregnancy. Only reason she came was because she thought maybe I could drain her swelling abdomen. So the head approach, I put on the ultrasound. I'm afraid there was no ascites there. There was just malignancy. Head approach, I could alter her medications a little bit to help. The main approach was sitting beside her and listening to that pain that you could imagine. A mum facing leaving her kids, the fear of how she was going to die. One of the things I explained to her how death might be to a 30-something woman with 5 kids. But that was one of her concerns. And you know what one other concern was? She was worried that she was a bad mum because she was leaving her kids. And she couldn't write them the messages that she knows she wanted to. She just burst into tears every time she started that stuff. So what were the hand stuff that we did? We got her a wheelchair so she could continue to go and watch her kids playing football. We got the physiotherapist to bandage her legs, so she could continue to make food for her kids. We're working with her to help her write those messages. Why am I saying this? I'm saying this because in our echoes in Palliative, we're sharing how to care and saying, you know what? Caring is really important. So when we're echoing across a community of palliative care community workers, it's all right to focus on getting a wheelchair. It's all right to focus on the important things for that person. So palliative, sometimes I wish there wasn't the word. I think it's just good care that often has been kicked out of medicine because we've become so medicalized.
Thank you so much, Max. And the other thing that was so powerful with all of you have mentioned too is, you mentioned the word presence and how important that is. And of course, there's the presence for the patients and the families that we serve, especially those that are clinical. But the other piece that I think about too is ECHO provides presence with our teams. And with all these people who are feeling so isolated, working in oftentimes very remote or rural communities. And that's the brilliance of ECHO, is it can break down those barriers. And it makes me think, Megan, like you have developed this connection across not just one community, but countries. And so I just wonder if you could share some insights of how you've been able to connect multiple different countries that have different cultures and traditions, and some of the approaches that you took to do that and develop that connectedness.
Yes, thank you, Chris. So I think early on, we had to recognize that there were some core principles of palliative care, some of the things I think we've shared about here today, and then how they come out and how you enact them in different places is different. And what my team, the leadership team's role is in building all these ECHO programs in different countries is to ask those questions and say, what does it mean in your community for someone to be cared for? What do they need when their child is coming to the end of their life? What support do they need? How do they experience that? And of course, that's different for every single person, every single parent and family whose child is ill. But there are patterns. And so what we have learned is there's like a core set of questions we have to ask when we go and we partner with a new country or a new place where we want to do an ECHO. And, that looks different in Bhutan. We ask, well, what is it like? How do children die? Where do they go? What are the expectations? And through, I attend a lot of ECHOs, not necessarily because I need to be there to lead them, because I have a huge team and we've created, kind of specialist teams for each of our countries, but because I have to listen to the cases to know what are they really facing and how are they thinking about these children and the problems that they have. So that's been a really core insight for me, is that as much as we come as the experts and we have some ideas about how to, give pain medications, we have a lot of questions that we ask, and then those cases that they bring to the ECHOs are an absolute gold mine for us to understand what does palliative care look like and what will it look like in that place.
Thank you, Megan. And Raj, it's just amazing to think about the journey that you have been on. You're the founder of Pallium India, and I just wonder if you could share with us a little bit more about Pallium India and the intersection it had in integration of ECHO and how that's had, in many ways, a global impact.
I told you we are greedy. We were looking after a few thousands of patients now. We want to reach 10 million people by 2030. And how could we do this in a country where palliative care was either unknown or something for the last few hours of life? And that's what ECHO empowered us with. We could reach huge numbers of people. There are people eager to learn. Doctors, nurses, social workers, and community volunteers with the heart, as Max said. They needed to be empowered. And that's where ECHO came in. We started in 2017, and till then, over decades, we were able to train a few hundreds of healthcare professionals in person. Ours is a huge country, home to almost 1/5 of the global population. It's not easy to get across from one corner to the other with the numerous problems we have. So now we are hopeful that we will be able to reach all of them at some point of time. But then there are challenges, no doubt. Yes, technical challenges, but more importantly, we are teaching people to do something vastly different from what they have been doing. During the COVID days, we trained about 1,200 doctors and almost 2,000 nurses in palliative care virtually. Great, isn't it? But here are the consequences. There was this doctor from northeast of India who was managing a critical care unit for COVID. And he could give a lot of comfort to a patient who was on BiPAP with small doses of morphine. Small doses of morphine, revolutionary to a person who has breathing difficulty. The person was a lot better, but 3 nurses got together. They couldn't stand this injustice. They said this doctor was trying to kill the patient. Complaints went up. All the doctors, including super specialist doctors, were up against arms. we had to be there for this man, to share international guidelines, to share validation with international textbooks, to give the evidence to the hospital authorities that this man was demonstrating compassion. So this is one thing that we will have to do a lot. How to use the ECHO platform not only to teach, but to be with them, mentoring them all the way through. And we are not doing that well enough. We will have to think about it. And not only in my country, I am sure this is valid for 86% of the global population. So that mentoring is one thing. The second part that I wanted to bring out is about the heart and the hands that Max talked about. It's easy to impart knowledge through ECHO. But how do you get that person to know how you interact with a patient? When I see one of our young doctors talking to a patient, just sitting like this, with eye contact, close enough, not standing down and talking to them. This they have to learn. And how do they? I suppose we should be using more and more videos, more and more role plays. I think we need to transform the ECHO program, keep modifying it so that we can train them in that. And the skills that are necessary, that also, I suppose, will have to be done with more videos and more interaction.
Thank you. Megan?
I just want to build a little bit off Dr. Raj's comments about mentoring and just our experiences of that being so important. I think this is a little bit unique to palliative care, and I'm sure many of you are doing ECHOs that involve palliative care or on palliative care. And perhaps we train a doctor. I have an example, a doctor in the Philippines. She got fellowship training in palliative care. They think this is a fantastic idea, see how many patients need this. She goes back to her hospital in the Philippines, and she gets a bit depressed because nobody else gets it, right? There's a big hospital full of people, and they're still giving care the old way. And she has this new model, the heart, hands, and mind model. And so it can be really hard for people in palliative care, newly trained people, to get that support and that mentoring. And so the ECHO, this doctor has come back into our ECHOs, and it's just a place to get support and to be like, I am not alone in this. They're facing the same problem in Bangladesh, in Nepal, in India. Everyone's having this challenge that their hospital doesn't understand palliative care. They're up against all these barriers. And that is a way to support them to develop new programs and not just kind of, get stuck.
Thank you so much. One thing it just came up that I wanted to ask all of you about. Resources vary across the world. And I know each of you have played a role, like just basic medications. Raj, you mentioned liquid morphine, but there's so many parts of our world that don't even have basic medications to help with symptoms. And it's just been inspiring to see how each of you have, number one, used what you've learned from ECHO to break down some of those barriers and help on a policy level across the world to make it a reality to get medications available and to teach people how to use these medications in an appropriate way as well. But I was just wondering if each of you or one of you could speak to that a little bit.
Could I put it back into a model in the West and in terms of COVID? March the 20th, we started our first ECHO for all the hospices and palliative care community across the UK in relation to COVID, because we were scared. Can you remember? We didn't know what was going to happen. We didn't know what we didn't know. And the palliative care community, what do we do? Should we continue to see patients? Do we do the outpatients? What do we do with our inpatient? All that stuff. through ECHO, we gathered that community right across the UK. We didn't know about our resources. PPE was available in one place, not place in the other. And we developed a community of practice to go through COVID together so that week on week we got the latest evidence, but we also gathered what was happening in different parts of the country, which we could then feed into the government to say, you need to change your services here. This is what we... so that community was so much more real than many governments who were saying, go to work on Tuesday, oh, don't go to work on Wednesday, and we're not sure what to do about work on Thursday, because they were making it up as, we were at least were, as a community, through ECHO, were negotiating and working it through. And so we also changed the research paradigm. That ECHO, over the course of a year, the academics listened to what the community was saying. These are the questions that we need to know in order to be able to treat patients. They turned it into research protocols. The community gathered the data quickly. Imagine palliative care data being gathered quickly, and in the course of a year, we published 12 articles on how palliative care would respond to COVID. So why am I giving you this stuff in relation to your question about the delivery of opioids and palliative care services? Because morphine and availability is such a slippery topic right across our world, different countries, different cultures, different responses. We have to gather that community to deal with all the issues. If you haven't involved law enforcement, if you haven't involved the judiciary, if you haven't involved the police, if you haven't involved, you can have the most wonderful echo in your world about the importance of morphine and what doses you need, but it's useless in the context of a country. And so I think the ECHO model is the model that we saw through responding to COVID, what we didn't know. It's about inclusively involving people who are the key stakeholders and just reminding them that this is about the pain relief of your mum, of your daughter, of your sister. I know there are problems, but you know what? Your mum's pain relief is really important. We've got to get around these. So you get where I'm coming. The ECHO model, I think, is the model which has been used in many different ways to transform the delivery of services. What do you think, Raj?
Absolutely, totally agreed. And particularly in relation to the access to opioids, 2 weeks back we were in Geneva working on another guideline for opioid access. We have your textbooks. We have the guidelines. Do you think they matter really for the 84% of the population? It's not real. And very often, in this matter of opioid access, it's like a game of tennis. You are here batting for pain relief. It's immediately returned by the addiction medicine specialists, saying, look at USA and Canada, look at the opioid deaths. The game goes on. Nobody wins. Only losers emerge. I think we also need to learn that we should be arguing for relief from suffering, recognizing that pain is suffering, but addiction also is suffering. We should be acknowledging its problems and arguing for safe access to opioids. And this is necessary to journalists, to educators, bureaucrats, and politicians. It took us 19 years to change the law concerning opioids in our country. But that's not enough. Now we have to make sure that the people there on the ground are aware of what is happening and how it is to be tackled. So our ECHO programs now, in the initial years, was all for professionals. Now it's also for people with lived experiences. We did 3 programs for people, families of patients. And they then become advocates. We also do programs for volunteers volunteers, training programs. So all this has to come together if we are really to make a change.
Can I just say one figure for you guys to remember is the figure of how much it would cost to give children who are dying in pain across the world access to opioids. That figure is only $1 million every year. Just $1 million. It's not about the money. It's about getting the team and the people and the commitment. And it's about mobilizing a population to say we cannot continue to let our children die in pain or our adults die in pain. And ECHO is about that. Mobilizing, recognizing everyone's a teacher, everyone's a learner. And in this, we need to be respectful, because another figure for you to remember is that 95% of end-of-life care isn't delivered by experts with degrees. It's delivered by families across the world. And we have the privilege of helping and supporting those families. And we shouldn't want to displace those families with our expertise. We've got to begin with commending them for all that they are doing and working alongside them, not displacing them, alongside them to continue to deliver that care. If we set up our models of hospices and palliative, we are going to do the world a disservice, because we need to work with the care force who are currently and will be for our lifetimes delivering that care.
Thank you so much, Max. Some words that I heard that were so helpful is, again, there's so many different needs, right? Families, caregivers. I also heard Raj say it's so important that we understand the contextualization. Each country, each community has a different context to understand how to address issues, and that's the beauty of ECHO. And so I just wonder from all of you to maybe share about what are the lessons learned from your palliative care ECHO that really apply across all ECHOs. Like I think we've talked about interdisciplinary perspectives. We've talked about self-care in some ways and breaking down isolation. But I just wonder if you can share a little bit about what have you learned from your own ECHOs that apply maybe to all ECHOs?
I think one lesson that Max taught me early on was that your ECHO is going to evolve. Your model is not fixed. 10 years ago when we did our ECHO training, immersion training, this is how you run an ECHO. And don't be afraid to change that. And we listened to our participants. We have an ECHO for residents, for postgraduate medicine residents in India on palliative medicine. And we listened to them, and they said, what we really want is to have small group interactions with the expert teachers. So we said, okay, let's put in breakout rooms. And then they said, you know what, best practices in education is that we use a flipped classroom model. And we're like, well, I don't know if that fits with ECHO. A flipped classroom, if everybody, just so you know, you ask your participants to do some pre-material, like pre-reading or watch a video ahead of time, and then they come to the ECHO prepared to actually discuss and interact. And so you don't do a lot of didactic teaching in the ECHO. So, that would not be the official ECHO model. But we said, if that's what they want this flipped classroom model. They're self-directed learners. We made videos. We basically recycled videos that we gave them ahead of time each week, 20-minute video. Then they come prepared to the ECHO, and it's discussion, and it's in breakout rooms. When Zoom invented the breakout rooms, we were on that immediately. We said, let's use those. And so, and we didn't call up the ECHO Institute and say, could we please use a flipped classroom with breakout rooms? We just did it, and then we evaluated it, and the feedback was, because the residents had been in this ECHO when it was the traditional model, and then post once it went to this flipped classroom breakout. And the feedback was fantastic. They said, this is exactly what we want. So I think that's my insight.
Thank you, Megan. Max, you shared too a little bit about sustainability and just again, sometimes we get stuck in our perspective that an echo needs to go on forever for it to be successful. And you've taught me so much about that we need to shift that perspective. And if you could speak a little bit to that.
We as palliative care doctors, we above all should recognize when an echo is dying and the time comes for a good death, and we shouldn't be worried about that. But dragging an echo on when people are not getting fed at that particular echo trough is inappropriate and unhelpful. And I guess the fundamentals of echo are the respect, the listening, everyone a teacher, everyone a learner, that support. Those are the fundamentals not to be messed with. But whether you have breakout rooms or case presentations or a 20-minute PowerPoint, or those things are negotiable. Building that community is not negotiable. Building trust is not negotiable. That is the energy of sustainability. And at our setup days, when we run in the Echo, we ask the community, what are your objectives? What would make you, looking back over the past year, think, I've used my time well in attending these Echoes? And we set those are the objectives. And those are the objectives that we evaluate as to whether that network has achieved its goals. So no longer are the Echo participants, if you like, the laboratory rats being examined by the evaluators. They are evaluating themselves, whether they have achieved what they have set out for themselves to achieve. And once they've achieved that, well, maybe that's the end, or maybe they want to achieve new things. But remember, our Echo participants, they're our guests. They are the heroes that we were talking about. And they are very intelligent and very bright about knowing just what is important. Listen to them.
Thank you, Max. I see we have about 10 minutes, and I want to make sure that we open up the floor to questions. And so there are going to be, I think, some people who have microphones. So we have a question right over here. So invite your question or comments. And if you could just share your name and your organization and where you're from, that would be great.
Hello.
We have another. There we go.
Hello.
Testing. Okay, it's on now. Hi, I'm Rachel Mutro. I'm with the Missouri Telehealth Network and Show Me Echo program. We currently don't have palliative care echo in our portfolio, and we're thinking about it. And one of the things, this is a little bit off topic with the questions that you've had so far. One of the things that I always think about with echo is that it's not a panacea. It usually doesn't solve a whole problem. And when I talk to people, I like to think about what part of a multi-pronged approach echo would be. And my organization called Missouri Telehealth Network, a lot of times we think telehealth is one of those prongs. And I was just wondering, in the areas that you work, have you seen telemedicine used alongside of echo for some of the direct patient care work that you do in palliative care?
Great question. Raj.
Thank you for the question. I should have mentioned that earlier. I mentioned that where palliative care is poorly accessible, where it is not known, where it is confused with only care for the dying, in all those situations, the training will have to be supplemented with continued mentoring. And how can we mentor? So, thank you. Telehealth programs are something that we brought alongside because we needed dedicated people to handle that. When the question comes from 2,000 miles away about a patient and the challenge, we had to do this. Today, I believe what we do is not called part of the echo, but your question makes me realize that it is indeed part of the whole thing. Thank you.
Could I just comment again? We've used ECHO initially broadly to support a community, and then the community has come back and said, well, actually, we'd really benefit from a clinic. So there's a 10-minute slot that we could refer patients into and get instant response. So the ECHO has facilitated the development of a service. But ECHO is never the goal. The goal is, if your goal in Missouri is to improve end-of-life care, maybe using ECHO as a way of discovering with providers how they could maybe use some of the new technology, new ways to develop a service. It doesn't have to be based on ECHO, but ECHO can be a great way of engaging with the key stakeholders to work out how that system could be delivered.
Thank you, Max. And we have another question over here.
Yeah. My name is Ujjwal, and I'm from ECHO, India. My question is that patients who are terminally ill and their families, they're not just in physical pain, but in a lot of mental trauma as well. And they just don't need medication. They also need empathy from their doctors. So do we have any ECHO programs which train caregivers in showing empathy and how, you can provide mental succor to not just the patients, but their families as well? Because, in my own personal experience, I was in a lot of pain. I kind of underwent an operation, and when I communicated to the doctor that I'm facing a lot of pain, I wasn't kind of treated in an empathetic way, So just wanted to have a question around that. So,
Great question.
Ujjwal, all our palliative care training programs have this strong component of psycho-socio-spiritual support. Without that, leave alone palliative care, I believe healthcare would be incomplete. What happened to you following your fracture was total injustice on the part of a possibly well-meaning surgeon who was used to abusing his power. And that has to change. And it is not a separate program, but all our palliative care programs have this strong component. We have to teach them. We use videos. We also use role plays.
Could I also say something on the positive side? At the Indian Association conference in Bangalore, there was representation there from cardiology, from nephrology, from respiratory, from surgery. And India has moved way ahead of the West in recognizing from those individual specialties the importance of end-of-life care. Yes, a long way to go, but that degree of engagement, I haven't seen it in other countries. The recognition that just because we're cardiologists, we also have to develop our empathy skills. And it is happening. It's a long journey to make, but that commitment, India is leading the way on that.
Yeah, and I think that often the ECHO is a way to support that mental shift for providers, because that's the hardest part for them, is that the whole medical culture that they go back and practice in is not having that approach. And so even if they learn this new approach, they need ongoing mentorship and support to sort of change the dialogue in their clinical work, in the field, in the hospitals, in the clinics where they work, to say, now I see things in a different way. It's not just about that he needs to take the medication and he's non-compliant. It's about why is he not taking that medicine? And then that turns out it's because the roof is leaking.
And I would say one thing I was just going to add to that as well is, again, on our ECHOs, the interdisciplinary team model is so important. But having who's your facilitator? On our ECHOs, it's not always the provider facilitating. We have our chaplain facilitate, our social workers facilitate. And again, it emphasizes the importance of that holistic perspective. And so that's just a suggestion too, is looking at who you emphasize and have on your team to be able to get that global view. There was another question over here. And this will be our last question, so this is great. Yes. Okay, and I'll repeat it for everyone to hear, so.
Hi, my name's Marjorie Nisnoltz. I'm a research coordinator at Mount Sinai Hospital in New York and a program manager for the intestinal failure echo. First, I just want to do a quick personal side note. This was a particularly exciting talk for me to attend because just kind of by chance, when I was in college 10 plus years ago, I actually worked and trained at Palliative, India, under Dr. Raj. It's okay if you don't remember me. That's, but yeah, so it feels a little serendipitous to be here. But when I was there, I remember that there was a kind of like a support group for patients and their families to kind of come together and talk. And I was wondering if you've ever considered having an echo where the patients are the participants and they're the ones presenting the cases and giving feedback sort of, under supervision of providers and clinicians, and how that might look and if there are certain challenges to that.
So thank you. I hope you will not run away and I'll be able to say hello to you. But we have not got to programs for patients yet. Seems difficult, a bit scary. Maybe we'll get to that someday, but we certainly have programs for families. What you saw was an in-person meeting of bereaved people, Unar Awakening. But what we now also have is this virtual program for them, so that not only are their problems answered and not only are they able to share their experiences, but they also become activists. Seeing that I have a few seconds left, do I have to go there to ask a question to the panelists?
No.
Arising from that, what made you spend time in low and middle income countries, all three of you, so much? And you could have been comfortable in your home. You did not make money doing that. You did that because, why? What? Because I am asking that question. Because many people here would be asking themselves, oh, if there is that much suffering, how can I help? How can they help and what will they get out of it?
Thank you, Raj. I've got 20 seconds or less. So I felt that it would not be enough to just see the patients in Canada and treat them and know that I had done a good job. I felt that there was so much more suffering in the world and I needed to take a step and join others in addressing that. And so I encourage everyone to think, would that be some step you could take? And not to think I'm going to go there and tell and they're going to do these things that I'm an expert in, but to join and walk alongside and listen and understand and say, how can we share in the burden of this suffering and work on this together? And it has been the most rewarding experience of my life. And you will not be disappointed if you do this work. And you will feel that your life has a bigger meaning and is part of a bigger picture. And it kind of counteracts all the negative and depressing things that you see on social media and in the news on some level.
Thank you, Megan. Well, I just want to share with everyone that's here. I am just so inspired by all of you in the room. We all have our stories again, right? And I am so excited we get to share them. And I'm so excited that I get to share the stage with these three remarkable people. One person, Raj, who's right next to me, we have a unique opportunity. So he just published a book called Walk with the Weary, Life-Changing Lessons in Healthcare. and he's going to do a book signing after this, right here on the side. And actually, Project Echo has purchased a limited number of books, and so it'll be kind of first come, first serve to get a free book. But we also have books to purchase if those run out. But I encourage all of you to meet with Raj or any of us after the session. But again, what a joy that we come together with hearts of service and a hope to make the world a better place. And it's so humbling to be with this community. So thank you.